Good morning, everybody. Good morning, everybody, and welcome to AIM Impact on Your Health. AIM Impact on Your Health, where every day our goal is to have you learn at least one thing to help you live better and longer. AIM Impact on Your Health is heard each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney, and I'm with you each and every Monday, Wednesday, and Friday from 8 to 9. AIM Impact on Your Health, where each day you'll find current medical news, knowledgeable guests, fascinating health topics, and of course, where we do encourage you to call in to join in. Been a lengthy little vacation. I hope you enjoyed your 4th of July. I know I did. We're back in the full swing in a very hot month of July with a hot number of guests. This is Top Doc Summer. We're going to visit with all of them. A little bit of that in a moment. Today, our special guest, a local doctor, one I've actually known for many, many years, a plastic surgeon. His name is James Barber. We're going to be talking about cancer screening, cancer risk analysis. It's now, its time has come. It looks as though if it can't be done by your insurance, it's reasonable enough you can do it on your own. You'll see what we mean by this as the day ensues with the advanced molecular diagnostics testing. Done in the office now, and Dr. James Barber is going to explain it to us. So in the course of our discussion with Dr. Jimmy Barber today, if you want to call and ask a question or make a comment, the number, of course, is and will be 412-825-6262. That's 412-825-6262. Cancer screening and risk analysis done in the office with insurance coverage to boot. Well, big change, big do-over. So, what about the rest of the month? Well, the top docs are going to start coming at you rather rapidly. On Wednesday, Dr. Charles Schwengel, a cancer doctor from Arizona, is going to be with us. A rather unique and spiritual component to his treatment of cancer. On Friday, you don't want to miss, we're going to launch with Beresha, the world's, how's this phrase? The world's only thermogenic fat-burning coffee. I know all this trouble that Dr. Oz got in with the green bean. I know that one. We'll get in no trouble here. Fat-burning coffee, unbelievable. One company makes it. We're going to bring them here on Friday and just launch this whole concept of the products by a company known as Beresha. You're going to hear a lot about Beresha in the up-and-coming weeks. You'll first hear about it this Friday. The next Monday, another top doc will be with us. His name is Nicholas Meyer. He is a biological dentist, and he also conducts his practice out in Phoenix, Arizona. As I've told you, he has the unique distinction of being Dr. Edward Condrat's dentist, and I think that's probably how we all got to meet Dr. Nicholas Meyer, our guest for 1 week today, talking about biological dentistry. Then a week later, on the 23rd, Lee Cowden's going to come back. He was here talking to us about an emotional component with respect to chronic disease. He also now going to talk about detoxification and his cancer treatment approaches. It seems like everybody out in the state of Arizona, in particular those who are in the area of Phoenix, all have an offering in this arena. So that's the way the month stacks up as I have it right now. I'll be giving you more of the guests. We've got a couple more slots to fill. I'll let you know as they are filled with who and which one of the remaining top docs will be coming to visit with us. Don't forget the eye treatment program. If you suffer from macular degeneration or glaucoma, or if you suffer from diabetic retinopathy, you are sort of in a bad way if you only treat via the conventional method, because that means you're getting no treatment at all. You get a pretty intelligent person to monitor you as you have vision that's just going to continue to deteriorate. What a depressing spot to be in. What a scary spot to be in. You can take charge and reverse those eye diseases in 3 days and get started on a new track, a way that you are in control and get that vision back that you've lost. This is the famous Dr. Ed Condrut treatment program, 3-day program. We offer them here in the office. This month's program will be held on the 21st, the 22nd, and the 23rd. Hope if you got an intention of wanting to be involved with this, you got plenty of time. Give us a call here at 724-942-3002. Ask for Sarah. She'll get you lined up and get the records off to Dr. Ed Condrut. He does participate with every single patient that we're going to manage. He gets those records. He programs the microcurrent machine, and we are in constant contact with one another through the entire 3-day program. We test you at the beginning. We test you 3 days later. The difference is nothing short of miraculous. Once again, the number, 724-942-3002. Now, jump on the Ozone Express. As you should well know by now, we're doing some wonderful things around here, whether it's systemic disease or whether they're local pain problems. Ozone and the use of it has just completely revolutionized what I've come to expect in the way of responses for treating pretty serious diseases, ones that took a difficult amount of time and never clearly was able to eradicate. Now, with Ozone, it's quite possible. So, finally, give us a call at 724-942-3002. Tell Kim you'd like to jump on the Ozone Express. She'll tell you how, in fact, that will take place, and I'll see you soon. All right, we're going to take a short break. A fascinating topic today, for sure. As much as cancer is in the air and much as you're concerned about your own risk with respect to it, you got a family history of this stuff? Well, if you do, they can figure out your probability of maybe contracting a form of cancer. If you knew about it ahead of time, what would you do? We're going to find out about that through Dr. James Barber. We'll be back in a moment with Dr. Jimmy Barber talking about cancer risk assessment.
Years. We offer metabolic nutrition.
Alrighty, we got them. Give me 2 seconds.
Okay.
Therapy, chelation therapy.
Good morning, ladies and gentlemen. Welcome back once again to AIM Impact on Your Health. Heard here in KHB 620, each and every Monday, Wednesday, and Friday from 8 to 9. I'm Dr. Dennis Courtney with you today on a Monday morning version of the show, and a good friend of mine, known him for many years, services a month ago and is involved in a fascinating project. The more I heard about it, I said, I got to hear more. And was able to bring him aboard to you today so he can explain it. This thing about the cancer issue permeates our lives, permeates our families. We've got risk developing and would like to be able to do something about it, would we not? Now, just take a listen to these few quotes. I think it sets a good tone for where we're about to go with Dr. Barber. Here it comes. Quotations. 10 years ago, it would have taken a factory full of machines the size of fridge freezers costing millions of dollars. Now you're talking about doing DNA sequencing on a chip. This comes from Life Technologies President Peter Sylvester. And showing a chip not bigger than a Scrabble tile. He said that their mapping of the first human genome took 13 years and $3 billion. 5 years ago, it was down to 1 million. Last year, it was down to tens of thousands. And now, to thousands, possibly even hundreds. The final quote, when movie star Angelina Jolie went public about her double mastectomy in May and said she chose that course after genetic testing indicated an 87% risk of breast cancer. Costs of the gene testing were upwards of $3,000, which may or may not be covered by insurance. However, get a load of this. Under Obamacare, genetic counseling and testing must be provided without patient cost sharing for women whose family history indicates high risk. Enough of the quotes. Are you titillated enough to learn more about what you might feel is your best edge against cancer? We're going to learn that with Dr. James Barber. We're going to welcome him now. Say good morning, Jimmy. Thanks for coming aboard today.
Dennis, it is my pleasure, my man. I appreciate you having me here today.
But Jimmy, I've always sort of smiled when your name's involved. It just never ceases to amaze me where your name will come up, what project you're involved with, and our paths have crossed so many times in the last 10 to 20 years. This one caught me a little bit off guard. You are, after all, a plastic surgeon and a doggone good one to boot. So why don't you maybe fill me in on how Dr. James Barber, plastic surgeon extraordinaire, gets involved with this project?
Okay, Dan, it goes back to my history. My mom we're from Newcastle, and my mom passed away at 58, and it began to say, hey, listen, how come my mother died at 58 and somebody else lived to be 100, 110 years old? And I looked at my family, per se, and to give you an example, my mother died from plasma cell myeloma. My brother had prostate cancer. His wife had breast cancer. My cousin died from breast cancer. My best friend died from pancreatic cancer. My dad had pancreatic cancer. My uncle died from leukemia. His brother died from leukemia. And I knew back in those days, I mean, of all the industries, et cetera, and I began to say, why is this happening? I had the privilege of writing a book called The Forever Factor, where I looked at all the factors that it could play into how we age, looking at the environmental things, obviously, the stresses in our life, but also the genetics of our lives. So I began to study those intensively and said, there's something going on here that we just don't know. All we see as doctors are the reports we get. This is your cholesterol. This is your liver function. We don't see below the surface. What is causing those to give us those results? What is the genetics involved? What is the metabolism involved? And I began to look at this, and I was approached by a buddy of mine, Jim Kramer. Jim played football in a national championship team with that in 1976. He was a rep, and he said, Jimmy, we're going to get a group together called Vista Healthcare, and we're going to look at that personalized medicine. We're going to look at how we age and what we do. And his partner at that time, and still our partner, is a guy named Ron Lindquist. Ron developed the EpiPen. He was the guy who had the idea, developed the EpiPen, has run 3 or 4 groups on the New York Stock Exchange, and subsequently been, aided by a group now in Texas, Jim Dixon and Tina Cohen down there. We've been aided by their group. And we have a chief science officer now, is Braden Gernashek, who's a pharmacist here, and a very, very good one and a very astute young man. But actually, we looked at this and said, okay, medicine is changing now. When we went to school, it was all about, take 2 aspirin, see me in the morning. Trial and error medicine. This is, this will work for you. If it doesn't, we'll try something else. This is looking at the individual patient now and saying, okay, what are the risks that you have in taking certain medications, and what is your propensity for certain cancers that we now can look at and look at you and say, okay, you have a family history of this, of genetic causes for your cancer, of diseases, etc. Let's look at you individually and see how we can do this. So we put the group together, and we've been approached now by a number of cutting-edge technologies. One of them being what we call a prevent test that can actually look at 8 different cancers and say, hey, this is how you have a predisposition for this cancer. You mentioned Angelina Jolie. Angelina Jolie had what we call BRCA1, BRCA2. And you are correct. She has about an 87% chance of getting cancer, and she had a family history of it. She said, hey, I don't want to go through all that agony. I'm going to have bilateral breast, mastectomy. She also is now considering, because they have up to a 40 and 47% chance of getting ovarian cancer, of having oophorectomy. In fact, now it's recommended that women who have BRCA1, BRCA2, after you have your children at 35 to 40, consider having your ovaries out because you have a high risk for cancer. And we know men can get this. It has an association with prostate cancer, etc. So we put this group together, Dan, and began to look at all the phases of personalized medicine. In other words, giving you a medication that we know is not going to cause you to bleed to death, one that you may not become addicted to as a pain med. Looking at cancers and saying, hey, you have a high predisposition for this cancer. These are the things that you can do to help prevent that and be able to take the screenings regularly to be able to do. But then that's how we put it together, and Vista Healthcare now has reps all over the country. We've been approached by a number of different companies, and I could go on and on about the number of technologies that we now have to look at neurotransmitters, to look at different phases of our lives, to be able to see how we act as an individual instead of the one trial and error medicine that we had up until this time.
Jimmy, I maybe in a sense with a lot of apologies, when I asked you how you get involved with this, and you start ticking off this family member, that family member,
right.
It took about a minute and a half, and you went through a pretty good litany of your direct and indirect family members who had to succumb to cancers. With that kind of a pedigree, Jimmy, my goodness gracious, it's no wonder why this says something that is so interested you because of your own risk, wouldn't you say, Jim?
Absolutely, Dan. Think about this. You get somebody in your family that has cancer. I mean, those family members should be tested. There are things that, we can look at you now and say, okay, your brother had this cancer. All right, you don't have to worry. You don't have that risk. Or you do have that risk. Okay, and here's the things that you can do. I mean, do you drink a lot? Do you smoke? Do you eat, healthy foods? Do you exercise? There are all these things that we now know we can institute to help offset some of these cancers. And if there's some things that we can't do, then, hey, get screened. You have a propensity in your family for prostate cancer. Make sure you get a digital rectal exam. Make sure you get a PSA levels. Make sure you see this. Get a colonoscopy. Make sure you don't have risk for colon cancer. Get breast exams. Make sure you get mammograms or all the different types of new technologies that we're saying. One of the things we're talking about down the road is 3D imaging that may now replace a lot of the mammography because it's more accurate. So all these things now, these are things that we can look at somebody and say, okay, you have a high potential for this cancer. These are the things that you can do. And genetic counseling is offered to the patient. These are the things to reduce your risk for these cancers. And here's what you should do regularly to get screened for these cancers so that you don't have to go through the agony of this. And that's in cancers alone. When you look at, all these different type of things, think about how many people a year, Dan, take medications and bleed to death. You're 2 million people a year on Plavix and, and Coumadin alone. 1.1% of those people die, and 20% of them are admitted to the hospital within the first 60 days for bleeding problems because we can't balance this. My dad just recently passed away. It'll be a year here in August. And to give you an example, my dad was a foster child. He quit school in 6th grade because his foster father, I guess, would get drunk, and my dad said he would beat him up. He went to the war at 18. My dad came back. He was a guard at the Nuremberg trials, married my mom. Came back, worked in a cement factory for years, made 87 cents an hour when we started. We had nothing in our lives, like a lot of people in Western Pennsylvania. And my 2 brothers and I slept in the same room. And all we had was love with my family, and that's all we knew from my dad and my mom. My dad, when a guy actually pushed him, broke his hip. My dad weighed 95 pounds. He was laying up in Masonic Village here in Sewickley, and I went to see him. He's black and blue from head to foot. And I, asked his doctor, who's a good buddy of mine, and he said, we're trying to get his INR balanced, trying to get his levels, that we know there's not too much.
He's bleeding all over the place.
Yeah, and he's black and blue. So I test myself. And we get back, when you get it back, it's in either with the pharmacogenetic testing, it's red or green or yellow zone to tell you, hey, don't take this. This is when it can hurt you, or this is a good one. Go ahead, it's a green light. Then I came back and did mine, and there it was. I mean, it was warning, make sure you don't take this medication. And I looked and I said, no wonder, I got this gene from my dad. So it all makes sense when you look at it. Our dad and our mother and our families pass down the genes to us. And if there's something that's wrong and something a little bit different in their genes, those are the things that we have to be aware of in our lives that can help affect what we're doing, what medications we can take, which ones we can't take, and then which cancers we can get. So it's a blossoming field of medicine right now, looking at everything that affects us to be able to see what is good for us and what's not good for us. So this is where we are. Personalized medicine is here to stay. Many of the big medical centers now, Vanderbilt University, Mayo Clinic, Cleveland Clinic, all these things are now instituting you regularly. Anybody goes on a blood center is tested genetically at these universities. Everybody has stent therapy, etc. They're now trying to decrease the adverse effects that we can see with these, which cause tons of money, tons of aggravation, death, litigation costs, etc. So it's a win-win for everybody.
And Jimmy, you perked a lot of ears, including mine, with the potential problems that lay out there familially. Could you take a little bit of time and walk my listeners through? I mean, out there they just had their own interest peaked. They're already doing some summations in their own mind about the number of family members, close family members, moms and dads, and primary family members. They got this picture in their mind. Walk us through, if somebody has this interest, how it is that they can take it from the interest level of this moment to actualize a test literally available to them in their doctor's office.
Well, it's a very, very simple test. It's what we call a buccal swab test. In other words, these tests, and there's a number of tests right now. One for the cancer predispositions we talked about, which will look at colorectal cancer, breast cancer, ovarian cancer, endometrial, prostate, pancreas, stomach, and skin cancers, melanoma, etc. And in the pharmacogenetic testing, we'll look at number of medications. It'll look at beta blockers, all the things we take for blood pressure, all the blood thinners we take, Coumadin and Plavix and all that. It'll look at the pain medications that we take. It'll look at the psychotropic for depression, etc. Diabetic drugs, statin drugs. You literally now can do a buccal swab, just a little Q-tip in the inside of your mouth, in your doctor's office. That'll be sent in. The lab then processes that within 5-7 working days. The doctor will get back a report. On the cancers, it'll say, okay, you have no risk for these cancers, even though your family members might have had it. Or you have a risk for this particular cancer. Here's genetic counseling that'll tell you what are the things that you can do to help prevent this, and these are the tests that you can run, and these are how often you should get these. It'll lay out a game plan for you. On the pharmacogenetic testing, it'll get back the doctor a report in the red zone with all the medications that, hey, be careful, don't take these. These can cause severe effects. If it's a blood thinner and you take it and you're a different metabolizer, that's what we're really looking at, is how the medications are processed. Different phase than the cancer genes, but how your medication, how your liver, how your enzymes process these medications and break them down. Do you get enough of those, to be able to make it effective, or do you get too much of them and make an adverse effect? Very simply, what we talk about is this. The doctor can test you and send it in. Metabolizers can be of different phases. You can be, and this is very simple to understand, you can be a poor metabolizer. That means you have the genes that don't make this medication work for you. Those patients roughly get about 28% of the efficacy of that medication. And to put that into standard terms, if you look at Vicodin and Percocet, all the things we prescribe as doctors, only 28% of that pain med works for you. That means you take 2 or 3 or 4 or 5 of them to get the same effect that you would if you were a normal metabolizer. Mm-hmm. And that effect, you can become physically addicted and dependent on those medications, and you become an addictive person with that. Or you can get too much of it. You can get what we call a rapid metabolizer, or an ultra-rapid. It comes into your system so quickly that you get the toxicities. You get somnolent. You get constipated. Or you go into respiratory depression and can die based upon how you handle that medication. Dan, I'll tell you what, this startled me. There's actually a black box warning now on over between 100 and 200 medications, stating the gene and how you metabolize, how this can adversely affect you. They have a story there, and this is amazing. A woman who gave birth was on, on contraceptives, and then gave birth, got off of those, gave birth, and was taking codeine, 30 milligrams a day. She was getting constipated and getting somnolent. She was what we call an ultra-rapid metabolizer, getting all these bad symptoms. She cut back the dose to half, 15 milligrams a day. The baby was a normal metabolizer. She was breastfeeding at 13 days, and the baby died because the baby got 40 times the lethal dose. She broke it down so quickly, all this medication was in her body, she was getting all the side effects. The baby handled this normally as a normal person would, a normal baby, got 40 times the lethal dose and died. So these now are black box warnings on women, and 30% of women who have babies are on codeine. These are things that we can now prevent because we can now test somebody before we put them on medications and say, this is how you're going to affect you. This is how it's going to work in your body, and this is the side effects you can have by not knowing this. So these are the things we can do. Predict cancers and give you a game plan. Look at medications and say which ones will hurt you and which ones will work for you. And in a sense, the patient becomes more compliant. He's not going to spend 15 million copays trying to get to where he wants to go. The doctor is going to be, look like he's a hero now because he's going to put you on something. Only 58% of Vicodin and Percocet, as many as we prescribe, only 58% of prescription medications work like that. And that's why, because we're not testing the patients beforehand.
Now, let's just take the medication side. I think it's fascinating. Everybody out there, if they take meds, and there are a number of people that do, you've just raised an awareness component for them that if they now could take this done by a buccal smear also when it comes to the drugs. Is that true?
Yep.
Really? So, go ahead, Jimmy. Go.
Yeah, and it's basically these are available. The number of tests that are becoming available now are absolutely amazing to be able to do a number of different things. We can actually, the new research in this then is now going to what we call inducers and inhibitors. In other words, we take an antifungal, we take an antibiotic. We eat certain foods, and you can see that on certain foods now. Don't take pineapple with this. Don't do grapefruit with this. All these foods pass through the same genes that we take in our body. They all pass through the liver. The liver processes these. We break down the food. We assimilate what we need to be able to be functional, and what we don't need, we excrete. All these things interact with the medications we want to take. And the new research now will look at all these medications. It will start looking at all the other things we put into our lives and say, these are the things that are good for you, and these are the things that are not good for you, trying to make this medication work. The effect of personalized medicine now is to get to the bottom line. What is the best thing for this particular patient? Not generalizing it, not throwing it out there and hoping it works, looking at that patient and saying, this is the thing that can work, this is the thing that should work for this patient, and doing this beforehand instead of after the fact.
Now, everybody knows what they take, and knowing that there could be a possibility that there's a problem here, by the mere fact that you could jot that down on a piece of paper, do a buccal smear. Talk to me about, when it comes to the meds, an insurance coverage for that kind of testing. Is that an option?
Most insurance companies pay for it. Medicare pays for it. Most insurance companies pay for this. Now, even Medicaid in a number of states is paying for this because they now realize, and this is from their standpoint, somebody has a stroke, basically it costs, between $17,000 and $40,000. If you can do this, and your genes never change, it's going to be the same the rest of your life. You can get this done when you're born. You can get this done when you're 30. You can get this done when you're 50. No matter when you do this, your genes are never going to change. So if you can prevent all the bad happenings, I'll give you an example. I went down to Tennessee and gave a talk for about 30 doctors. Okay, and the lady that invited me down was giving this story. She ran the surgery centers in Knoxville. She stood up and told us, she said, in 1985, I had a stroke. For the next 20, 25 years, they worked me up. She said, I had 6 hospitalizations, I had lumbar punctures, I had medicine after medicine, I had TIA after TIA, et cetera, all these bad things happening where nobody could figure out what it was. One of the tests that we do with the genetic testing is what we call MTHFR. MTHFR is just related to what we call homocysteine. Homocysteine means inflammation to the blood vessels that can lead to clogging there and cause stroke. It can lead to a heart attack. And, with cancer technologies, methotrexate toxicity. No one ever tested her for that. She went 20 or 25 years. We finally tested it. She was tested at a university, and we tested within 5 days if you have MTHFR. She said, had I known this 25 years ago, now they put her on, prophylaxis for it. She said, I would not have to go through all this aggravation, changed my life, ruined my life in a lot of respects, all the money that was spent. Now the insurance companies are realizing that if we can prevent these things from happening, we may take out, some money now to pay for it, but in the long run, all the patients who have to be hospitalized, all the patients who have to do this, it saves money. So it wins for the hospitals. It wins for the doctors. It wins for the patient. It wins for the insurance companies. Now with Obamacare, hospitals, et cetera, are going to be penalized if there's readmission. This is something that benefits them because now you can prevent readmissions, as we talked about before. Patients on blood thinners, 20% of them are admitted within the first 60 days because of problems. Now we can prevent those problems. This is something that insurance companies are looking at. Medicare, believe me, Medicare won't pay for anything unless they do. And when they put black box warnings on these citing the genes, when you see these from all the different medical societies now, they're actually pointing it out and saying to this, the patient, saying to the doctor, saying to the insurance company, we realize what the problem is. This is what we're going to do, and this is how we can stop it.
By the way, the MTHFR, completely corrected with folic acid. Go figure.
Yep, that can help to do that. I'll give you another example. There's a test we do called Factor 2 and Factor 5. Factor 2 and Factor 5 are the leading cause of throwing clots, embolies in this country, thrombus. One of the girls in my office, her daughter was dating a young man. The guy was 21 years old, good friend of hers, dating her, hung out for years. The kid threw a clot and died at 21 years old.
Oh,
they basically found out he was homozygous, which means he had two bad genes for this. He had over 100-fold risk of throwing a clot. I pointed out to you, women on contraceptives, they have a 30-fold risk of throwing a clot just because they're on contraceptives, and 30% of women may be on contraceptives. If they have a factor 5 deficiency and they're on contraceptives, they're a walking time bomb. You can test these patients beforehand to tell them they have this, they have this potential to do it. Parade magazine is funny. Now I'm getting the Sunday paper, Pittsburgh Post, et cetera. I'm reading it over Christmas time and said, okay, your family's coming to visit you. Look at this right now and ask them, who had cancer, who did this, so you can pick up particular risks you might have. And then there was a little story in there about a lady talking about her father who died. And she said, no one would ever know this. You would never see this. He had factor 5, right? And he died from throwing a clot. She said, every member of my family now has been tested. Some of us have it, some of us don't. These are things that you can now look at, and let's prevent the adverse effects before they occur instead of afterwards. I mean, you don't want to have to cry over something. You can rejoice and say, hey, I nipped it in the bud and I took care of it.
Great explanation on the meds. I want to do this, Jimmy. I want to take a short break and come back, and let's concentrate on the cancer side. There are so many cancers. I got a list. I mean, it's 3 pages long, Jimmy, on how many cancers are detectable with this genetic testing. And I'd like for you to spend a little bit of time on that, emphasizing that, okay?
Sounds good, then.
Yeah, folks, you're with James Barber. Seems like he knows what he's talking about, doesn't it? By the way, you can also learn that we got this going in the office here. So what we're talking about today is nothing but a AAA if, in fact, you'd like to be involved with the testing. More on the cancer side of the equation when we return with James Barber. We'll be right back. Good morning, ladies and gentlemen. Welcome back once again to the AIM Impact on Your Health. Here on a Monday morning post-vacation show, we're here today learning an awful lot about something that probably has a meaning for every single one of you listening to us, whether it's you directly or a family member. The cancer issue is there. And so a lot of people taking a lot of medicines too. Turns out there's some unique testing done by buccal smears. That's just a swab on the inside of the cheek. And we got Dr. James Barber, plastic surgeon renowned here from the Western Pennsylvania area, with a pretty interesting family history that just compelled him to learn more. We got him invading his morning this morning. Thank you, Jimmy, and allow us to invade your privacy at this hour and talking about the cancers, Jimmy. Spend some time a bit. I'm looking at the information in front of me. A lot of cancers are able to be tested for. Tell me how that one works.
Well, I'll tell you, Dan, we know that a lot of patients basically have family histories of cancer. Everybody listening out there probably either has a family member that's gone through it or has somebody, that they know has gone through cancer. We now know that we can develop a risk for this cancer environmentally. People who smoke know that potentially, hey, they can get lung cancer. You shouldn't smoke. People who drink a lot, are at risk for cancer. But genetic testing for cancer now helps predict that a patient will develop a cancer in their lifetime. It doesn't say you will, but they'll tell you, hey, you have a high disposition for this. Now, who may be at risk? Well, patients who have a family history of the cancer, relatives who have it, patients who have had, family members with early onset of this cancer. That may say that, heads up for them. Or patients who, have, multiple site cancers knowing this. So, now actually the American Society of Clinical Oncology, which is called ASCA, they recommend genetic testing when a person has an individual or family history of it. When the test for the genetic condition, is adequately interpreted by a physician to be able to do it. And if you have a diagnosis early on in your life of one form of cancer, you may be prone to a lot of these. But now we can look at, beyond what Angelina Jolie did. I mean, that was done by a company called Myriad at that time. They used technology called PCR to be able to do this. There have now been 2 reports, one out of the University of Seattle in Washington and now in the Journal of Molecular Diagnostics, saying that there's now a new form to be able to do this called next generation sequencing. It can literally look and do 500 scans of your DNA. And as it does those scans, it can predict with less than 0.1% of false positives and false negatives, your ability to be able to tell a patient that they have cancer. And we can now look at 8 different cancers. We'll study 34 different genes and 8 different cancers to tell this patient you have this predisposition or you do not have this predisposition. The requirements, for instance, insurances will pay for these. Medicare will pay for this up to the age of less than 67 because they figure after that age, there's a lot of things that can play into this. But it will look at this to be able to predispose you for all these cancers. And you can look at each one of these. Now, breast cancer, we know that, that's one of the most common female cancers in the United States. 1 in 8 women in their lifetime will get it. And approximately 5 to 10% of breast cancers will be hereditary. Hereditary cancers are caused by mutation. So we can look at these patients now and, what are some of the factors that increase your risk for that? Well, family history, genetic mutations. If you have dense breast tissue, that can do it sometimes. Early onset of menstruation, or late menstruation can do it. A history of radiation you had to the chest area at some time, not having children or having them later in life, or postmenopausal hormone therapy. We now know that can add to breast cancer. Or increased age, your obesity, or alcoholism. So when you look at those factors, genetically we can say, this is what you have. But there's some things you can do to reduce those risks. Lose weight. Don't drink as much. Don't smoke as much. Exercise more. Preventive medication sometimes your oncologist can, provide for you. There's a lot of different things that we can provide, and every single cancer that we see has this. We know that if you have breast cancer, ovarian cancer is the ninth most common cancer in women, but it ranks 5th as the cause of cancer death because it's a silent cancer. We now know that, if the cancer does not run in the family, approximately 10 to 15% is hereditary. So 10 to 15% of these are hereditary. And women who have an abnormal scan can have up to 44% risk of being diagnosed with breast cancer if you have a BRCA1, BRCA2, let's say. So once again, we can look at each one of these cancers. If their family risk increase with ovarian, if you have a family history of it, mutations once again, increasing age, or never having been pregnant. So how do you reduce your risk there? Well, preventive therapy, and consider, birth control pills. Those are some of the things that doctors will put them on. So you can look at every one of these 8 different cancers then and say, okay, here's the risk that you have. Here's some of the things that you can help offset that risk. And if there's nothing that you can do to offset that risk, then make sure you get tested routinely so you can nip it in the bud and catch it as early as possible to do preventive things. And now, as Angelina Jolie did, there's preventive surgeries that patients can now have. If you have a high risk for this and you're so worried about it, it can help offset that risk of doing it. My brother had prostate cancer. I've been tested now. I actually had 2 biopsies done. They helped, show that. The first one was kind of ambiguous. They didn't know. The second one said, no, you don't have it. So now I go back, at least every 6 months to a year, get a digital rectal exam to be able to be examined, to be able to do that. And if you have an abnormal gene for prostate cancer, you're 20 times more likely to develop prostate cancer in your lifetime. So these are the things that we can look at this patient and say, hey, here's your heads up. Here's the things you can do. Do them, and if not, make sure you get tested routinely.
Now, I'm looking, and I'm doing a little bit of math work. You had thrown some out here, but let me ask this question. They got 34 different genes that are associated with forms of cancer. And by the way, one of those genes alone could have an ability to foretell multiple cancers, 5, 6, 7, 8, 9 of them in some cases.
Yep.
So that one gene can really forecast problems in a whole bunch of different zip codes in the body. But if you put down on the paper, if you say, because I'm looking at this, a few lines asked you about your family history. So if you wrote breast cancer, maybe your mom died of breast cancer, maybe you had an aunt that died of breast cancer. So you write down breast cancer, maternal. Then there are, as I checked out from the 34 genes, 16 of the genes are able to identify breast cancers. Does that mean that they run it for all 16 of the genes?
They will run a test, depending on, it's insurance-based sometimes on this, how many genes will run, as for the cost, etc. But they will run it for all 16 genes. They will run 34 different genes covering 8 different cancers because, as you said, there's a cross, a cross between certain genes.
Yeah, they cross over.
Yeah. So they'll run a test for 34 different genes looking at 8 different cancers, and then they will give the doctor a readout, a printout that will say, okay, here's the abnormal gene we found. Now, here are actually some of the research papers concerning that gene and how they got it, and they'll tell them, listen, this is what you can do. Here's the genetic counselor that will contact you to say, these are the things that we just talked about. Here's the things you can reduce your risks, and here's how often you should be able to get a test showing what, that could help prevent this from becoming, apparent in your lifetime.
You just answered this in a way I didn't think you were. So now I'm going to rephrase my question, Jimmy, because I already think what you just told me, if I heard it right, makes this absolutely the go-to form of testing. Because I heard you say that when you submit a buccal smear, that you may have put down breast cancer or a prostate or whatever you put down, but they're going to run the table. They're going to test all 34 genes for every gene for every potential cancer. You may have written down one, but they're going to let you know you stand with all of them. Did I hear it right?
Yeah, that's what they can do. That's one of the options they can do because there's a cross reactivity between them. We know that if you have a BRCA1, BRCA2, you know what I mean. Basically, that's what Angelina really had. You can have a potential for breast cancer, but we know there's a cross reactivity. If you are a male and have a BRCA1, BRCA2 mutation, you can get prostate cancer or pancreatic cancer. If you are a female that has it, a BRCA1, the breast cancer, you said up to 87%. But they also have a 20 to 44% chance of getting ovarian cancer. They have up to 2 to 4% chance of getting pancreatic cancer in doing that. If you have a BRCA2, though, once again, a male can have, up to a 6 to 8% chance of having a BRCA2 breast cancer, but he can have a 20% chance of getting prostate cancer and a 6% chance of getting pancreatic cancer. So BRCA1, BRCA2, for instance, can be tied into ovarian, prostate, pancreatic, and melanoma. So it'll give you all these potentials to say, hey, this is where you are. You're one of that 2 to 4% that have a BRCA1, BRCA2, but you have a increased risk for pancreatic cancer. These are the things that you can help do to offset that. So it'll look at all these and then tie it in and say, hey, these are your potentials and this is what you're having. And once again, it's, the doctor can order just a one test to be able to do it, or you can order, a myriad of these tests. And typically what they'll do is just order the entire panel because of the cross-reactivity of these genes.
Exactly right. That's just so all-inclusive, James.
Why would somebody then not want to do this? I mean, I understand people get, you get scared if you're going to have, that doesn't mean you're going to get it. But I'd rather know from the beginning that I have this potential. These are the things I can do. Instead of sitting back and saying, my grandmother died from this, my aunt died from this, my cousin died from this, I wonder if I have it. Well, at least, instead of all these, going to bed every night going, well, I hope I don't get this. At least you can say, well, I have a potential for it. I've offset it. And believe me, I'm going to take every precaution of getting the test done routinely so that, God forbid, if I do get it, I'm going to catch it early enough that it's never going to affect my life.
Give us a quick walkthrough. Okay, people are listening to me right now, and we're already set for these. By the way, the gentleman brought a whole bunch of these envelopes in, so it's not as though, we have to wait to put this in place. So for the listener who really had their interest piqued, this is doable almost immediately just by calling us up. And
absolutely. And they can come into your office. You can sit down there. What they want to do, and for insurances to pay for it, you have to have 1 to 2 members of your family that have some degree of cancer. Now, basically, there's HIPAA. You don't have to release that, whatever. But it's got to be say, okay, is there a reason for doing this? I mean, yeah, my aunt has this, my cousin has this, fine. Whatever cancers they have. You can now, say, okay, there's a reason for doing this. Insurance companies don't want to do this on anybody that, may live to be 150 that has no family history, et cetera. But they can come into the office, get a buccal swab that, how long does that take? A minute and a half to do? Give a history to be able to tell the doctor what's going on so that he has some insight to why you're doing this, what the potential is for this. The doctor does the swab, and within 5-7 days or so, working days, they'll get the result back telling this patient this. If it's negative, the patient can say, great, I can do this as long as I don't, do all the environmental things that can add to this, smoke until I get lung cancer, et cetera. But if it's positive, then they will direct the patient to either their genetic counselors or other to say, these are the things that you can do to help, prevent the genetic predisposition from showing up. These are the things you can do. So it is an all-inclusive, program for the patient to be able to be tested in the doctor's office there, to be able to be tested with both the cancer and the same way if hey, my uncle bled to death from Plavix. Can I get tested to make sure I can take this medication? Or, I had 2 members of my family get addicted to medication. Should I be taking this medication? The nice thing about these genes, they'll never change. You can get your prevent test to tell about your cancer predispositions, or you can get the other test based upon the medications your one's going to take, because you'll get a card for the rest of your life that if you go on vacation, for instance, just transgress back to the medications again. If you go on a vacation and you get an accident, you have to go to the hospital and somebody wants to put you on this medication, you can say, wait a minute, don't do that. I've been tested, don't put me on that. Your doctor died, he moves. You don't know what medications you can take. Now you can literally have it for the rest of your life, an insurance policy. You can test for your cancers, you can test for the medications you may take in your lifetime, and it's an insurance policy that you now own for you individually, just not the one trial and error medicine we've always had.
Now I'm looking on the literature, and I see there is a website. I always love when they're available to pass on to my listeners. Am I right about this? It's geneidlab.com. Is that right?
That is correct. But that's something that they go to the doctor. They can read up on some of this stuff. But basically, your physician should be the one. Then they should come to your office. You can sit down with them and tell them, this is why we're doing this. This is what we're going to do. You can interpret the test for them. Basically, you can walk them through the the environmental things that they can help prevent that. And you can basically look and say, hey, this is how we're going to treat this. You don't have to worry about this, but these are the things we're going to do. Make sure you start getting a colonoscopy at this date. Make sure you get a mammogram. These are the things you can direct the patient to be able to do.
This is a winner. This is a winner.
I say that we're just tipping the iceberg on this. This is a form of medicine that is now here to stay. We didn't have it in medical school when I went. They're now instituting it at the University of Florida, Ohio State University, et cetera. They're now looking at this and putting this in all medical school curriculums to let doctors know. And as we talked about in the break, 98% of doctors said that they would be interested in learning about genetic medication, medicine. Less than 10% said they had any knowledge of it. That's because we weren't trained. This is a new form of medicine. In the future, then what they're going to do, this is going to be amazing. They're going to look and say, okay, you have a predisposition for these cancers. You have a predisposition for Alzheimer's or for this disease. They're now going to develop nanotechnologies, medications that will look at that gene, whether it be for cancer or Alzheimer's or Parkinson's, etc. It will shut the gene down before it can mutate. So you'll do your genetic testing. The medication will go after that gene and say, okay, you haven't become a bad gene yet. You are in the future because you have that gene. It's going to shut it down so that it never, ever mutates, so that you never get that potential for that disease or for that cancer. That's where personalized medicine, that's where medication, that's where medicine is going in the future.
The time has come.
Unbelievable, man. It is every day when you get stuff like this, you start reading about it. They're now developing things that, they help, they just did tests where, you may only have to take one shot in your lifetime instead of statin drugs because it'll affect cholesterol levels. They're doing things where you can actually now, there's been some controversy on the, type 1 diabetes to be able to generate, insulin. Now, there's some people kind of poo-poo the research that was recently done, but all these things are going to look at every disease we have and all kinds of cancers and all types of things we have and be able to affect the genes that are now causing these and reverse those so that we don't have to live with that in our lifetime.
Well, Dr. Barber, I want to thank you so much.
No, it was my pleasure, my man. Anything for you, big guy.
Well, we've known each other for so long, and it always amazes me where I find you, where you surface. This one is a big one, Jimmy. This may be one of the biggest ones you ever been into, and I think that I'm a parallel universe person with you. This is something that I need to promote as a physician, and the fact that we already have this stuff in the office. For the listener out there, we're just a phone call away. So if you're interested in this kind of testing, give us a call at 724-942-3002. We'll help facilitate it. You say a 7-day turnaround, and we can have a consult and talk about what we learned and what to do about it.
Absolutely, Jen. This is something that will save lives, change medicine, change lives, save lives. It is something, there are very few things in life that are a win-win for everybody, and this is it. I mean, this is something that's going to revolutionize medicine and revolutionize our lives.
Well, you've touched me. Thank you so much for coming aboard this morning.
Appreciate it.
Our paths will cross shortly, I'm sure, but until then, Jimmy, thank you so much, and we'll be talking to one another.
Take care.
Okay.
Bye-bye.
There you have it, folks. Dr. James Barber, plastic surgeon extraordinaire, known for years, but boy, with that family history of his, I can see why he wanted to make sure that he learned as much about this new testing that is now available. And when it comes to the medicine part, that's easy. That's covered because you're on the med. And when it comes to the cancer part, as long as you've got 2 family members, that will be the ticket so that this becomes a covered service for you too. But best I can tell you, make sure, come on in and we can get this started for you too. Now, with just a minute or two to go, what do we got going on here? We got Charles Schwengel coming here talking about cancers. He's going to show you his unique approach, a spiritual one. And I'm really in favor of this. After hearing him at the Top Docs Conference, which he was definitely one of the 20 top alternative doctors, he's going to be talking about cancer therapy. That's on Wednesday. So don't forget on Friday, the launch of a new company called Beresha with the world, and I mean the world's only thermogenically made coffee. You drink the coffee, you lose the weight. Dr. Oz, it's not the green stuff. It's not the green extract. There's actually a product. It's a one of a kind. We're going to be talking about Beresha's products on 11th. And those of you who get some titillation out of these products, we're going to have a tasting. It's going to be in August now. It's going to be the second week in August. So you can mark it off. That's going to be on the 13th, Wednesday evening here in my office. We'll have a whole bunch of this stuff, whether it's the teas, the coffees. There's even a lemonade. They're all low glycemic. And this company, I believe, is on its way up and up. and I'll introduce her to you. On the 14th, which is 1 week today, Nicholas Meyer is going to be our biological dentist. Going to come aboard and talk about that which he knows best, the Dr. Condrat's dentist, of course. And then Lee Cowden returns on the 23rd, talking about cancer and detox. He really lit this up, talking about our switchboard up when he was here last time, and that was last month on the 18th, where he talked about emotions and disease as well as Lyme's disease. The man is so versatile. After all, we had a little joke when he was on the show with us. He's a board-certified cardiologist. Didn't talk about cardiology once, not one time. Man, so eclectic. We got bongers in the background signaling our time out here. Hope you enjoyed our show today. Look forward to seeing you on Wednesday. Until then, this is Dr. Dennis Courtney on behalf of Dr. James Barber saying so long for AIM Impact on Your Health.